Other questions, we can move on to our next talk. This is losing control in complex uveitis cases by Dr. Manisha Agarwal. Ma'am is a renowned vitreoretina and uveitis specialist heading the VR and uveitis department at Shroff Charity Eye Hospital. Ma'am, we'd be delighted to listen to you. Can we have the presentation, please?
So very good afternoon to all of you, and thank you, Samendra, for making me a part of this wonderful IC. I think my timer is not right. I have 14 minutes, you've put it on 8. So I'll be basically sharing a few case examples where the diagnosis was a dilemma, and that is where the thought process comes whether you would really like to take another opinion or send the patient across to somebody else. Can I have my slides moving, please? So my first patient is a young 3-year-old girl child presented with pain and redness in the left eye for last 4 months and diagnosed 4 months back as a case of anterior uveitis not responding to treatment. She was put on prednisolone, and because of the topical steroids, she was already having a secondary glaucoma which was being treated with 2 anti-glaucoma medications. And on examination, when this child presented to me, child had this fluffy white material in the anterior chamber, which was anybody can confuse it like a very extensive uveitis entity having a lot of fibrinous reaction in the anterior chamber. But what we need to really question our mind is, somebody having anterior uveitis, why will the child not respond to topical steroids? If it's inflammatory, it has to respond to steroids. And that is where you don't really need to step up the steroids, add oral steroids, but actually question the diagnosis, because nobody is going to be making such a blunder. When I did a cursory examination in the OPD, the central fundus was all normal. We did a B scan. The B scan was also normal because the child is not very cooperative. We did all the baseline investigations, and everything came out to be normal. So this is the time when you have to take a call and say, okay, I have done an examination, but probably that's not enough, and that's how I planned this child for an examination under anesthesia. And what I found was that the ciliary processes also were studied with the similar kind of white fluffy material. Now, it's a question whether we want to again subject this child to another GA and think what we need to do, or take a chance and do an AC tap. And what you have to be cautious is, like I think Nitin also mentioned, when you have any patient of extremes of age, too young or too old, they are unlikely to have an inflammatory response. And what you have to keep in mind are the masquerades. So I did an AC tap, and I did a long intracorneal track, thinking that it might come out to be something as a surprise, using a 30 gauge needle to avoid any kind of metastasis. And rightly so, this child showed up these numerous basophilic cohesive cells, very much suggestive of a retinoblastoma. Now, what was surprising was, on a fundus examination, there is absolutely no evidence of retinoblastoma. On a B scan also, there is no evidence. But here we are, our AC tap is showing these malignant cells. So this child underwent an enucleation, and we sent the eyeball to JB sir, and he confirmed that we were in fact dealing with retinoblastoma. And also the histopathology confirmed that beyond doubt this was a retinoblastoma. Since the optic nerve head, which was free of the tumor, nothing else was required. And then we reviewed the literature where we went wrong, and it came out to be an entity called diffuse anterior retinoblastoma. And what is surprising in a diffuse anterior retinoblastoma is that they have microscopic foci of the tumor involving the retina. We all know retinoblastoma is a tumor of retina, so it should show up in the retina. But why it didn't show up? Because this entity has microscopic foci, and which are very subtle, and you may not clinically pick up. So this is something we have to keep in mind when we are having. So what were the lessons learned from this? It was a young child with very unusual fluffy exudates in the anterior chamber, not responding to steroids for last 4 months, already developing complications in the form of a secondary glaucoma. Now it is the time to revise diagnosis, or send it for another opinion, or do an interventional diagnosis in the form of an EUA that we did, and we also did an AC tap. So that is the time when you have to think of some other diagnosis. My slides are again not moving. Now coming to the second case. So this is an 18-year-old boy, not vaccinated with BCG, having a diminution of vision for last 6 months. And in the left eye, what you see is a hyperemic disc, so you know you're dealing with an inflammatory pathology. You have an exudative RD, and you also have the subretinal yellowish lesion in the macular area. And the vision is as low as hand movements close to face. So I go ahead, I do a fundus fluorescein angiography, which just shows a hot disc with stippled hyperfluorescence, suggestive of, again, nothing very conclusive, but some inflammatory pathology is all that I know. So I have to draw a kind of a differential diagnosis in my mind. So the first thing which comes in India is tuberculosis, chronic infections like fungal, and something lower in the DD list is a lymphoproliferative disorder. But to my surprise, when I investigate this child, the Mantoux is 0, which is very much against a diagnosis of a tuberculosis. So again in this child, I subject this child to a vitreous biopsy. So again an interventional diagnosis, I go ahead, I collect the sample of the vitreous right above the lesion. Where we go wrong is when we do an AC tab, which will just suck out the clear fluid. When we do a vitreous biopsy, we'll take the sample of the anterior vitreous, though the lesion is lying at the back. And I collect the sample and I subject it to the investigation. So my lab technician tells me that the acid fast staining is negative and the PCR for MTB is also negative. So I'm again lost in the diagnosis. And now the sample starts showing some kind of a growth on the culture plate. And you have gram-positive filamentous bacilli. And it comes out to be a nocardia species, which again was not in my mind because I've never seen a patient of nocardia. So when we reviewed the literature, we realized that there can be an involvement of CNS by nocardia. So we went ahead and did an MRI of the brain to rule out intracranial nocardiosis. And we put this patient on the specific treatment along with Visalon, and the child responded well. And we also published this case because it was a learning for us that nocardia can actually resemble a tubercular infection by having a subretinal abscess. So here, as the title suggests by Samendra given to me, here we retained the case and we did an interventional diagnostic vitrectomy and lab testing to make a diagnosis which was definitive and helped in the management of this young child. Now coming to my next case, a 45-year-old female patient with diminution of vision in both the eyes for last 4 months, diagnosed to have VKH elsewhere, given 3 doses of IVMP followed by oral steroids and not responding, and then put on methotrexate, and then again was not responding, so was put on azathioprine. Still not responding and with no improvement of vision, and this lady was apparently known to some employee of mine in my hospital, and he said, "Aap ek dafa dekh lijiye, patient is not doing well." I was just questioning VKH diagnosis. I've never heard not responding to steroids and to immunosuppressants was something which was really taxing in my mind. There was no relevant past systemic history in this patient. So the vision was 1/60, less than N36, no evidence of any inflammatory cells, no evidence of any retinal break, extensive exudative retinal detachment. I depressed and depressed to locate a retinal break which would have solved my problem. I could see extensive subretinal gliotic bands. I could see a hyperemic disc, but I could not see any retinal break or a dialysis. And this is the left eye picture. The vision was 624 N18. You see this thick band, SRG band going through the macular area, and extensive retinal detachment, a hyperemic disc, which again was confusing in my mind that it's an inflammatory pathology. So I go ahead, I do an OCT. My problems increase further because I see this lesion, which resembles a PED. I see a bacillary layer detachment, which goes in favor of inflammatory pathology. A PED goes in favor of CSCR. I see a subretinal gliotic band, which goes in favor of a rhegmatogenous retinal detachment. So I had my mind boggling with all kinds of diagnoses. I see these septas, which go in favor of a VKH. So I just didn't know what I was dealing with. I did a fundus fluorescein angiography. The disc was hyperemic. The disc was hot. It showed some kind of leakage, and I had this diffuse kind of hyperfluorescence throughout the fundus. But it really didn't add to my diagnosis. I just noticed this pinpoint leaks, which go in favor again of a VKH or a posterior scleritis, but I really don't know what I was dealing with. So I put these questions in my mind: no response to steroids including IVMP, no response to 2 immunosuppressants. So I reassess the OCT images again. When you have a very busy OPD, you don't spend so much of time when you have done an investigation. So a good idea is send back the patient, sit in the evening and reassess the investigations that you have done. And what I saw in this particular patient was, if you very carefully see the OCT, these subtle bumps, what I noticed, and that was something which was really bothersome, that this is not something we see usually when we are dealing with an inflammatory pathology. So I called the patient back and I took a detailed history taking again from this patient, and she told me that she had a small nodule in the right breast 2 years back, which was diagnosed to be benign. I frankly wanted to buy time. I didn't know what diagnosis I was dealing with. So I said, okay, let's start from here. You go back and get your breast lump again reevaluated by your oncologist. The oncologist saw her, and to my utter surprise, this patient was lost for a follow-up. A good idea is to take up the phone number or the contact details of the patient. And when I called up, the husband picked up and he said, when I went back to the oncologist with my wife, she was diagnosed to have lumps in both the breasts. She had matted axillary lymph nodes, and she was advised a whole battery of investigations. And finally, she was diagnosed to have invasive ductal carcinoma grade 3 with leptomeningeal metastasis and both eye choroidal metastasis, along with bone metastasis. And she was put on hormonal radiation and chemotherapy. As far as the ocular treatment is concerned, since we are dealing with an exudative RD, we tried doing an external drainage, but because we had lost so much of time and there were subretinal gliotic bands, the retina would not settle with an external drainage, and finally I had to resort to a pars plana vitrectomy with silicone oil injection in both the eyes, which made the patient ambulatory, but we lost this patient in 6 months' time because we lost a lot of time initially treating her as a patient of VKH. And this is her 6 weeks post-op follow-up, where you find that the vision is considerably okay to make this patient ambulatory. So the clinical pearl to learn from this last case of mine is that the patient is not responding to treatment. It's time to revise your diagnosis, restart by taking a detailed history from the patient, run through all the investigations again peacefully, and take an expert opinion if your mind is getting blocked with a certain diagnosis. I remember my professors telling me, don't fall in love with the diagnosis that you have made, but you have to revise it if your patient is not doing well on the treatment that you have started, because you may have something very fatal which can really go wrong for your patient in future. So I would just conclude my talk by saying that any case of uveitis not responding to treatment, it's time to revise the diagnosis or take another opinion or refer the patient. Dealing with extremes of age of the patient, you must rule out the masquerades, and I'm sure Dr. Samendra is going to add more knowledge on masquerades. And if it is not diagnosed and treated on time, it at times can be fatal, like the last patient I showed to you. Thank you so much for your patient listening.
Thank you so much, ma'am, for sharing those unbelievable cases. Sometimes they make you question the very basis, the very concept of uveitis that you have learned. But the idea is to keep revising, and like you said, not to fall in love with your diagnosis, because it's always, you can always revise it,
so
go
here
back.
You can fall in love with every day with a new diagnosis.
With a new diagnosis.
Yeah.
Thank you so much.
Thank you.
Can we have some questions? Dr. Nitin has a comment to make.
Ma'am, in your first case, what is the role of ultrasound biomicroscopy in such kind of patients when there is nothing at the posterior back
So
segment?
in ultrasound biomicroscopy will surely have a role, but what happens is that here you had just fluffy material which was along the ciliary processes. And the other thing is that if it would have been an adult patient, we probably could have been able to do a UBM in our OPD. But here you had a 3-year-old child who would not have cooperated for a UBM without a GA. And we unfortunately don't have a UBM in our OT. So if an adult patient, surely yes, I would advocate doing a UBM.
Thank you, ma'am.
Thank you, ma'am. Can we have some questions from the audience regarding this kind of a case? I can see Dr. Ramakumar sitting in the audience. So, any comment from you?